Over 1 million seniors are hospitalized every single year from adverse drug reactions, not from diseases, not from accidents, from medications prescribed after routine doctor visits. And researchers at the Mayo Clinic and CDC have traced a significant portion of those hospitalizations back to one specific moment, the conversation in the exam room. Most seniors walk into that room and say too much, and it costs them their independence. So why did something as simple as mentioning a little fatigue become the trigger for a cascade of tests, referrals, and 5 new prescriptions? That is exactly what we are going to unpack. There are 3 specific things you should stop saying to your doctor after 65. They are backed by findings from the Mayo Clinic, AARP, and CDC research. And this is not about hiding things from your doctor. It is about protecting yourself the way doctors are trained to protect themselves. The third one shocks most people because it sounds completely harmless. There is a version of the American healthcare system that works beautifully. You go in, you describe what is wrong, your doctor fixes it, and you go home healthier than before. For patients under 50, that version is mostly real. But after 65, something shifts. The system begins to see you differently, and that difference has consequences most seniors never see coming. Dr. Emily Carter of the Mayo Clinic has documented what she calls the age flagging effect. Once a patient crosses 65, clinical protocols change. More tests get ordered, more specialists get looped in, more medications get added to the mix. It is not malicious, it is procedural. Doctors are operating inside a liability framework, and every symptom you report triggers a protocol, not a conversation, a protocol. The distinction matters more than most people realize because a conversation can end with a nod and a note to keep an eye on things. A protocol cannot. A protocol demands action. It demands documentation, follow-up, and a paper trail that justifies every decision made in that room. And once that paper trail begins, it is almost impossible to stop. Dr. Michael Thompson, whose research has been cited by AARP, found something even more striking. Seniors who practiced what he called selective non-disclosure, meaning they were thoughtful and strategic about which minor symptoms they volunteered, experienced 25% lower rates of overtreatment than those who reported everything freely. 25%. That is not a rounding error. That is a documented, measurable outcome. And it held across multiple patient populations, multiple geographic regions, and multiple types of clinical settings. This is not an anti-doctor message. Doctors are not the enemy. The system is the problem. And inside that system, the senior patient carries more risk than almost anyone else. 5 or more medications interacting in a single body, referral chains that take on a life of their own, diagnoses that follow you on paper for decades. The exam room is not just a place to get help. After 65, it is also a place where a single offhand comment can set something irreversible in motion. A senior's passing remark in a routine checkup would later become the exact thing that caused a 6-month spiral of tests, medications, and specialist visits. But in that moment, sitting under the fluorescent lights with the paper gown crinkling every time they shifted, it was just small talk. Picture a Tuesday morning appointment. Nothing urgent, just a routine checkup. The kind every responsible senior schedules twice a year. The waiting room smells faintly of antiseptic and old magazines. The chairs are hard plastic. A television in the corner plays a morning news segment nobody is watching. The doctor asks how things are going, and the patient, being honest, being cooperative, being a good patient, mentions something small, something barely worth bringing up. I've been a little tired lately. Or maybe, my knee aches sometimes when I climb stairs. Just mentioning it, just being thorough. What comes next is the part that still does not make sense. That single sentence, that one offhand comment, does not stay small. It cannot. Because the doctor sitting across from that patient is not just a healer, they are also a liability manager. They are operating inside a system that requires them to document, investigate, and respond to every reported symptom, especially in a patient over 65. Especially when that patient has a chart full of existing conditions and current medications. The physician opens the electronic health record, the cursor blinks, and the comment gets typed in. Logged, time-stamped, permanent. Logging it triggers a question. The question triggers a test. The test comes back with a borderline result, not alarming, but not perfectly clean either. So another test gets ordered, and then a referral. And then a specialist who has never met this patient before looks at a single data point on a screen and recommends a medication. Just to be safe. Just to stay ahead of it. The specialist does not know about the Tuesday morning comment. They only see the borderline result. That is all they need. That is all the system requires them to see. Think about that for a second. A comment about feeling a little tired on a Tuesday morning has now produced a new prescription. A prescription that interacts with 2 existing medications. A combination that the CDC has flagged as a high-risk profile in patients over 65. And nobody in that chain did anything wrong. Every single step followed protocol perfectly. The system worked exactly as designed, and the patient is worse off because of it. This is the overprescription pipeline, and it is not a theory. It is a documented, repeatable sequence that plays out in exam rooms across the country every single day. Minor symptom gets mentioned, diagnosis attempt begins, medication gets prescribed, side effects emerge, more medication gets added to manage the side effects. And the patient, who came in feeling a little tired, is now managing a 5-drug regimen with a follow-up scheduled every 6 weeks. Their calendar fills with appointments. Their kitchen counter fills with orange bottles. And the original complaint, the fatigue, the aching knee, has been buried under layers of clinical response. The CDC data on this is stark. Adverse drug reactions in seniors spike dramatically when 5 or more medications are combined. The risk does not increase gradually, it accelerates. Each additional drug added to the mix creates new interaction possibilities, new side effect profiles, new risks that no single doctor in a referral chain is fully tracking. The prescribing physician sees one piece, the specialist sees another. The pharmacist flags a potential interaction, but defers to the prescribing physician, and the patient is left holding all of them, trying to keep track of what to take with food, what to take on an empty stomach, and what absolutely cannot be taken within 4 hours of something else. Dr. Emily Carter's work at the Mayo Clinic specifically examined how the initial symptom report functions as a trigger point. Her findings showed that vague, low-severity complaints, the kind seniors routinely mention in passing, were among the most likely to initiate extended diagnostic sequences, not because the symptoms were serious, but because the system has no mechanism for receiving a minor complaint and doing nothing with it. Every input demands an output. Every mention demands a response. The clinical machine does not have an idle setting. What seniors rarely understand is that the exam room conversation is not a casual exchange. It is a clinical intake. Everything said in that room becomes part of a permanent medical record, and that record follows the patient into every future interaction with the healthcare system. A comment made in passing at age 67 can influence treatment decisions at 72, at 78, at 84. The record does not forget. The record does not contextualize. It simply stores. And every future physician who opens that file will see the notation, see the referral, see the prescription, and will build on top of it rather than question it. The seniors who understand this, who walk into that room knowing how the system processes information, they make different choices. Not dishonest choices, strategic ones. They learn which symptoms warrant immediate disclosure and which ones are better monitored privately before being reported. They learn the difference between a conversation and a clinical trigger. And that knowledge, according to Dr. Thompson's research, protects them in ways that passive cooperation simply cannot. The senior who mentioned feeling tired left the appointment believing they had received a clean bill of health. They had not. The prescription was already written, the referral was already scheduled, the pipeline had already started moving. And by the time the side effects appeared 3 weeks later, the dizziness, the disrupted sleep, the strange heaviness in the legs, the original comment was buried under 6 layers of follow-up documentation. Nobody was looking at the beginning of the chain anymore. Everyone was managing the middle of it. For a while, things actually seemed fine. The new medication appeared to be working, and the follow-up appointments felt routine. That did not last. But what nobody saw coming was that the second thing most seniors say, The one that seems even more innocent than mentioning fatigue triggers an entirely different kind of risk, one that most doctors will never warn you about. It is a Tuesday morning in the fall of 2022. The exam room is small, the fluorescent light hums overhead. The paper on the examination table crinkles every time the patient shifts their weight. A 68-year-old retired school teacher named Margaret sits waiting for her annual physical. Her hands are folded in her lap. She has a list in her purse, not of complaints, just of things she wanted to remember to mention. Because Margaret is thorough. Margaret is prepared. Margaret is a good patient. Margaret is not sick. She knows this. She feels, as she later tells her daughter, mostly fine. But Margaret was raised to be honest, and she was raised to believe that the more information you give your doctor, the better care you receive. So when Dr. Paulson walks in and asks how she's been feeling, Margaret does what good patients do. She tells him everything. She mentions the fatigue she noticed last month. She mentions the occasional ache in her lower back. She mentions that she has been feeling a little off lately, though she cannot quite explain what that means. 3 symptoms, all minor, all vague. And then Margaret made the one decision that changed everything. She said, "I just wanted to mention it in case it means something." It meant something, just not what she expected. Dr. Paulson documents all 3 complaints. This is not negligence. This is protocol. In the modern clinical system, every reported symptom becomes a data point. Every data point demands a response. Vague fatigue in a woman over 65 gets coded as a potential cardiac flag. Lower back aches get flagged for metabolic screening. Feeling off opens the door to neurological inquiry. Within 20 minutes, Margaret has 3 new referrals and a preliminary prescription for a low-dose beta blocker to address what Dr. Paulson calls possible early cardiovascular stress. Margaret does not have cardiovascular stress. She had a bad few weeks, but the machine does not distinguish between those 2 things. The machine only knows what it was told. This is the turning point, not a dramatic one. No alarms go off. No one raises their voice. Margaret simply nods, takes the prescription slip, and thanks her doctor for being so thorough. She drives home. She stops at the pharmacy. The fluorescent lights there are just as bright. The pharmacist counts out the pills and slides them into a white paper bag with a stapled receipt. Margaret takes the first pill that evening with a glass of water and a small sense of relief that someone is looking out for her. That prescription leads to a follow-up. The follow-up leads to a cardiology consult. The cardiology consult leads to a second medication to manage a side effect of the first. By March of 2023, Margaret is on 3 medications she was not on 6 months ago. Her daughter notices she seems slower, more tired, less herself. The very symptom Margaret mentioned, fatigue, is now significantly worse than it was on the morning she walked into that exam room. This decision seemed small at the time. It was not. The Mayo Clinic published findings confirming that seniors who report 3 or more minor symptoms in a single visit are 40% more likely to leave that appointment with a new prescription. 40%. That is not a typo. That is a clinically documented pattern, not an anomaly, not a fluke, a pattern that repeats across patient populations, across clinical settings, across the full geography of the American healthcare system. And the phrases that trigger it are not dramatic. They are the quiet, offhand phrases that feel like responsible communication. I've been feeling off lately. I get tired easily. I have some aches. These sentences sound harmless. Inside a clinical documentation system, they are anything but. Here is why this happens. Physicians operating under modern liability standards cannot hear a vague symptom and do nothing. If they document it and fail to act, they are exposed. So they act, they order tests, they write referrals, they prescribe, not because they are bad doctors, because the system they operate inside demands a response to every input. Your casual mention of fatigue is not received as casual. It is received as a clinical complaint requiring clinical action. The gap between those 2 things is where the damage happens. The phrases themselves carry weight that most patients do not understand. "I've been feeling off" is not a neutral statement to a physician treating a patient over 65. It is a potential early marker for a dozen conditions. "I get tired" easily maps directly onto cardiac, thyroid, and metabolic screening protocols. "I have some aches" opens pathways toward inflammation panels, bone density concerns, and pain management discussions. Each phrase is a door, and once you open it, you do not control what walks through. So what is the fix? It is not silence, it is precision. The filter is simple. Before you mention a symptom in a doctor's office, ask yourself 2 questions. Has this lasted more than 2 weeks? And has it meaningfully changed my daily life? If the answer to both is yes, report it. If the answer to either is no, consider waiting. Monitor it at home. Write it down in a notebook with the date and a brief description. Give it another week or 2. A symptom that resolves on its own was never a clinical issue. A symptom that persists and disrupts your function is exactly what your doctor needs to know. The difference between those 2 categories is the difference between appropriate care and a prescription cascade you did not need and cannot easily undo. Margaret eventually worked with a geriatric specialist who reviewed her full medication list and concluded that the beta blocker had been premature. It took 14 months to safely taper her off it. 14 months of side effects, follow-up appointments, adjusted dosages, and a daughter who kept asking why her mother seemed so diminished. All of it traceable back to one Tuesday morning and 3 vague sentences spoken in good faith by a woman who was simply trying to be a good patient. The system is not designed to protect you from your own honesty. That protection has to come from you. Dr. Susan Paulson saw it coming. She later told a colleague she had documented the symptoms because she had no other choice under current protocol. She said it quietly in a hallway between appointments, with her badge still clipped to her coat and a stack of patient files under her arm. Nobody listened to what she was actually saying, that the protocol itself was the problem, that the system was generating harm through its own internal logic, and that no individual physician operating inside it had the power to stop the chain once it started moving. She had watched it happen dozens of times. She had documented it dozens of times. And each time, the documentation became part of the very machine she was trying to describe. It is spring of 2024. A community health seminar is underway in Scottsdale, Arizona. 63 seniors sit in folding chairs inside a church fellowship hall. The room is warm. Someone has set out a folding table with coffee and store-bought cookies. A geriatric care consultant named Dr. Michael Thompson stands at the front of the room with no slides, no podium, just a microphone and 30 years of clinical observation. He is about to say something that will make half the audience deeply uncomfortable. He says, "The most medically literate seniors know what not to say as much as what to say." The room goes quiet. Not the polite quiet of an audience waiting for the next slide, the genuine quiet of people who have just heard something that does not fit the story they were told their whole lives. Dr. Thompson went on to describe a pattern he had observed across decades of geriatric practice. Seniors raised in the 1950s and 1960s were taught a specific relationship with authority. Doctors were trusted completely. You told them everything. You answered every question fully. You did not withhold. You did not filter. You were, above all, cooperative. That instinct, that deeply conditioned reflex toward full disclosure, was once a reasonable approach to medical care. In the modern clinical environment, Dr. Thompson argues, it has become a liability. The modern medical system is not designed for nuanced conversation. It is designed for documentation and protocol. Every word spoken in an exam room is a potential entry in a permanent medical record. That record follows you. It informs every future physician who opens your file. It shapes how insurance companies categorize your risk. It influences decisions about driving privileges, surgical eligibility, and in some cases, independent living assessments. When a senior mentions memory lapses, even minor, even entirely normal for their age, that notation can trigger a cognitive screening referral. When a senior mentions occasional dizziness, that can initiate a fall risk classification that restricts their activities. When a senior mentions feeling sad after a significant loss, that can open a psychiatric documentation pathway that is extraordinarily difficult to close. The words leave the room with you. They just go somewhere you cannot see. Being a good patient in the traditional sense can mean losing driving privileges, losing independence, or being placed on medications you do not need. That is not a hypothetical. That is a documented outcome pattern that geriatric specialists like Dr. Thompson have been raising alarms about since at least 2019. The AARP published a 2025 report citing Dr. Thompson directly, noting that seniors who practice what the report calls strategic communication with their physicians experience measurably better long-term health outcomes than those who default to full passive disclosure. The numbers are not marginal. They are significant enough that researchers are now calling for changes to how medical schools train physicians to receive patient information. Telling your doctor everything without filtering can actually lead to worse care, not better. That sentence is difficult to absorb. It contradicts something most people in that fellowship hall had believed for 60 or 70 years. But the data supports it. And the stories behind the data, the Margaret stories, the Tuesday morning stories, make it impossible to dismiss. The seniors in that fellowship hall in Scottsdale are not unusual. They are representative. They are the generation that built the modern healthcare system with their compliance, their trust, their willingness to show up and answer every question and follow every instruction. And now that same system, the one they helped sustain, is using their compliance against them, not out of malice, out of design. A design that was never updated to account for what happens when a patient is 71 years old, already on 4 medications, and mentions 3 vague symptoms in a single 15-minute appointment. Consider what passive disclosure actually looks like in practice. A 71-year-old man mentions to his physician that he has been having trouble sleeping. His doctor, following protocol, documents insomnia. That documentation triggers a sleep disorder screening. The screening leads to a prescription for a sedative hypnotic medication. That medication is later linked to increased fall risk in seniors. He falls, he fractures his hip, he spends 6 weeks in rehabilitation. He never fully returns to his previous level of independence. The chain began with 3 words, "I can't sleep." Words spoken in good faith, words that, in a different kind of system, might have prompted a conversation about sleep hygiene, stress, or caffeine intake. Instead, they became a clinical entry point that ended with a man who can no longer walk to his mailbox without holding the railing. 3 words, 1 fracture, a permanently altered life. The same instinct that built this generation's trust in medicine was quietly destroying their quality of life. Self-advocacy is the new standard of senior healthcare, not passive disclosure. That is not a radical statement. It is a clinical recommendation increasingly endorsed by geriatric specialists, patient advocacy organizations, and researchers who study medication overuse in aging populations. It means learning to distinguish between symptoms that require immediate reporting and symptoms that require monitoring. It means understanding that your medical record is a legal document, not a private conversation. It means recognizing that the physician across from you is operating inside a system with its own pressures, its own liability structures, and its own documentation requirements, and that your job is not to make their documentation easier. Your job is to protect your own health. Those 2 things are not always the same. Dr. Thompson ended his talk in Scottsdale with a line that several attendees later said they could not stop thinking about. He said, "Your doctor is not your confessor. You are not obligated to tell them everything. You are obligated to tell them what they need to know to help you." The room stayed quiet for a long moment after that. Then someone in the 3rd row raised their hand and asked the question everyone was thinking. If we cannot trust the system to protect us, what do we do? Dr. Thompson smiled. He said that was exactly the right question, and that the answer starts with understanding that the most powerful thing a senior can bring into an exam room is not a list of every symptom they have noticed. It is the judgment to know which ones belong on that list and which ones do not. This pattern is not unique to one type of complaint or one type of patient. The system defaults to elimination and intervention, not to optimization and watchful waiting. And until that changes structurally, the responsibility for navigating it falls on the patient. On you, on the person sitting in the chair with the paper cover, waiting for the doctor to walk in, deciding in real time what to say and what to hold back. That decision is not a betrayal of the medical relationship. According to the research, it may be the most medically sound decision you make all year.